Welcome to the last series or the last PowerPoint in the presentation of pathways and diagnosis. This last presentation is going to emphasize ischemic optic neuropathy. So hopefully you've joined us for the previous webinars and you understand the take-home message of these presentations is that we want you to understand how to maximize the use of your OCT in your practices. We want you to understand how to early diagnose and detect various conditions, including in this presentation ischemic optic neuropathy. I'm going to go through almost a rubric or an outline of something you can take back to your offices to incorporate this technology and again use it to its maximum potential. So in order to understand how to use OCT in the diagnosis and management of ischemic optic neuropathy, you have to understand the pathophysiology of the disease. Ischemic optic neuropathy, and we're going to focus primarily on the non-arteritic form for purposes of this presentation. They all have different pathophysiologies, but since this is the most common, that's what we're going to emphasize in this presentation. So if you go back to your days of optometry school, if you recall the blood supply to the eye, it's very important to understand this disease. So we start off with the powerhouse, which is the internal carotid artery. That's that large blood vessel in the back. The internal carotid artery feeds into the ophthalmic artery. The ophthalmic artery branches off into the central retinal artery and the posterior ciliary arteries. So in ION, we get some type of shut-off of blood flow or occlusion to the posterior ciliary arteries. It could be a total occlusion or it could be a partial occlusion. So that will dictate the presentation that we see clinically, depending on how much perfusion is cut off. But it's very important that you understand this schematic so you understand what happens to the nerve in various stages of the presentation of the condition. Here we have another schematic of what's happening within the blood vessel during this disease process. So in the normal eye, you can see that the blood vessels filled up beautifully with heavy blood cells. And those blood cells feed into the eye through the process that we just talked about, and the optic nerve gets a beautiful amount of perfusion. In ION, because there's that shutoff or that obstruction in blood flow, you can see the decreased amount or the decreased density of blood cells within the blood vessel. That results in poor perfusion to the nerve, which ultimately is going to result in edema and optic nerve head pallor. So if you think of it in this way, it truly makes a whole lot more sense than just trying to memorize that optic disc edema occurs and I'm not really sure why. The disease classification is broad, and each one has a different pathophysiology and presents in a different way. But just to give you a quick schematic, we have the anterior types and we have the posterior types. The anterior types can be broken into the non-arteritic and the arteritic. And again, for purposes of this presentation, we're going to discuss the non-arteritic. And then the posterior side, which is again arteritic, non-arteritic, and post-surgical. Okay, so there are some different terminologies, if you want to say, on how to classify these diseases. This is the final schematic to separate the anterior type from the posterior type. The anterior type affect the nerve, okay, and the disc. You can see the disc is the yellow ball. It affects 1 millimeter of the actual nerve space. Everything after that is considered posterior. So if it affects the disc or 1 millimeter after the disc, it's the anterior type. If it affects the actual tract there, or the nerve, then it's the posterior type. So hopefully through these little anatomical pictures that I showed you, the pathophysiology of the diseases makes more sense and you don't have to just memorize it. So now we go to the question that we've presented in every webinar. How can we use spectral domain OCT to help us in this condition? Most of our patients, most of our students, I should say, or most of us practitioners think of OCT as diagnosing diseases of the retina and glaucoma. We don't really think about it in terms of other conditions like optic disc edema. But essentially, it could be a very critical tool in helping us to diagnose the condition and manage it over time. Depending on when we pick up on the disease process, the testing is going to look completely different if it's an acute presentation versus a chronic presentation. And the OCT will help us look at the course of disease and diagnose it. So as a final tribute, this is the slide that has carried us through every presentation. You have to understand the anatomy of the OCT scan to understand how to interpret it. We know that OCT is a non-invasive test. It takes seconds to obtain behind a machine like a photo. It uses light waves, again, to obtain a tomographic or cross-sectional image of the retina. And on the right-hand side, you can see the cross-sectional image of the retina. The vitreous is on top, followed by your inner retinal space, your outer retinal space, your photoreceptors, which would be your IS-OS junction, the RPE, which is the hyperpigmented red line, and then your choroid. And then on the bottom, you can see how that cross-sectional image relates to a histological slide of the retina. You can see them side by side, and you can always refer back to an abnormal area on the OCT and look at it histologically to see where it's occurring. I want to emphasize one more point on this slide. The ganglion cell complex is a very hot topic in all types of eye disease, but especially in neuroophthalmology, because the ganglion cell complex houses the ganglion cells, which feed the optic nerve. So any abnormality to the ganglion cells could essentially result in a problem of the optic nerve. And we're going to go into more detail on that, but I wanted you to see here the ganglion cell complex and how it later on is going to affect the optic nerve, abnormalities of it. So the first step, which again we've presented in all of the webinars up to this point, for consistency's purposes, I'll go through it again. We want to get the technician involved. We want the technician to be trained in obtaining an excellent personal history that's specific to the exam process or to the disease process that we are looking at. So the patient's personal history for a patient that has optic disc edema or comes in complaining of recent onset decreased vision is going to look very different from a patient that may have glaucoma. There's particular parts of the history that your technician has to be trained to ask in these patients. So this is a schematic, again, or an outline of what I like to emphasize in a patient that I'm concerned has optic disc edema. Okay? We want to find out why the patient has poor perfusion to the nerve. And if I said optic disc edema, ION specifically in this case. Why does the patient have poor perfusion to the nerve? One of the main reasons, a lot of literature has been done, is nocturnal hypotension. If a patient's blood pressure drops in the evening before bed, that can result in poor perfusion to the nerve. It's the same pathophysiology as we were talking about with normal tension glaucoma. So if the patient has a drop in blood pressure at bedtime, that can result in poor perfusion to the nerve. And what I've showed you here is certain classes of medications. I'm not going to go through them in detail, but certain classes of medications that one of the side effects is actually nocturnal hypotension. So we need to ask specifically. A patient can say, well, I'm on an ACE inhibitor. They won't even know that. But let's say they have high blood pressure and they tell you they're on a blood pressure medicine. You need to know what blood pressure medicine that is, because particular blood pressure medicines are more prone to causing the blood pressure to drop in the evening than others. So we have the tricyclic antidepressants in it also. Okay, the blood pressure medications, the miscellaneous medications, the MAOI inhibitors. These medications are known to cause nocturnal hypotension. Very, very important to ask the patient. What about specific medications that affect the nerve directly? Because the ones we just talked about affect the nerve indirectly by causing nocturnal hypotension. But what about the medicines that have a direct impact on the nerve? They have one of their side effects would be an optic neuropathy, let's say. I gave you a list here of some of the main ones that I think of. The antiarrhythmics, TB, we've all heard of ethambutol toxicity, isoniazid toxicity. Okay, those would be medications that you need to know can result in optic nerve head problems. The chemotherapeutic agents, even tamoxifen is known to have some type of effect on the optic nerve. So again, you can use this printout and refer back to it on medications that on the top, at least of my list, of things that I would be worried about that indirectly affect the nerve. What about the patient's medical history? Okay, we mentioned nocturnal hypotension, a huge link between blood pressure that drops at night, poor perfusion to the nerve. Remember the pathophysiology. Okay, there's a cutoff or an obstruction to the short posterior ciliary arteries. So that would be a big risk factor. Sleep apnea. These patients stop breathing in the night, okay, for extended periods of time. If they stop breathing for extended periods of time, there's a cutoff in the blood supply getting to the eye, and it can result in an ION. So a lot of times we don't think about asking about sleep apnea, right? We think that's not in our realm of practice, but essentially it is, because it could have a poor effect on the eye. What about anatomical stuff on the ophthalmologic side of things? What if the patient has a small nerve? You know, we've all heard of discs at risk. Those crowded nerves, they have less blood supply to them because there's less blood vessels to a smaller nerve. That would be a patient that we would worry about of developing ION later on down the road. Okay. What about lifestyle? What are some of the problems in lifestyle that can lead to this? High blood pressure because of their medication that could ultimately result in nocturnal hypotension. So it's like a domino effect. Diabetes, again, poor ischemia, poor blood vessel supply, perfusion, poor blood vessel perfusion. Smoking and obesity, due to the inflammatory process that they have, the free radical formation that they have, they also affect how the blood flows. They may even lead to diabetes or other microvascular diseases. So once your technician has gotten an excellent personal history, and we make sure that we know the medications the patient's taking, and if we don't, we want to elicit it or get it from the primary doctor. That is worth your time. If it's something that you're considering is in your differential, that it's from a medication toxicity, that it's worth your time to call the doctor and actually get that information. Then we move on to family history. And again, if you were with us for the optic disc edema presentation, similarly with ION, this isn't something that runs in families. We don't think about an NAION being a familial disorder. But I mentioned in that presentation, and I mentioned in this presentation, always think of the rare entities. Leber's can cause swollen nerves, familial hyperlipidemia, which again can result in poor perfusion, could run in families. So it's not on the top of my list. I don't usually say, well, do you have a family history of optic disc edema, right? It's not something that we usually think of, but it's something that should be in the back of your head, way back with the zebras. Once we've obtained all of the histories, we have the technician move on with the screening OCT. And I've emphasized in each of these webinars, and I'll emphasize again, that it does not matter which technology you use, as long as the technology has all of the preemptive screening that you want. So it could be a Cirrus, it could be an OptiView, it could be a Heidelberg, or anything else you choose, but we want to make sure that the test gets all of the screening information about retinal nerve thickness, nerve fibrillary, or GCC. Okay? So here again is the printout of the eye wellness screening exam. Here's a patient that comes in, maybe with a problem in their right eye. Okay? You do the screening OCT, what are you going to find out? The B scans look essentially normal. Okay? What about your retinal thickness map? We talked a lot about retinal thickness map, how that blue color indicates a thinner number than would be expected for this patient. It's abnormal. What about the GCC? Right? The GCC is abnormal. The GCC has that red color there, indicating that it's way outside of way outside of norms. Okay? Way outside of norms. So here you have a patient. It's not showing up on the B scan, so the retinal scan looks pretty normal, but something's going on in that ganglion cell complex. And recall from the previous part where I showed you the scan, that the GCC refers to inner retinal tissue. It's made up of the nerve fiber layer, the ganglion cell layer, and the inner plexiform layer. So it's made up of that inner retinal tissue, but not only is it made up of inner retinal tissue, it also houses the axons, dendrites, and cell bodies of the ganglion cells. So again, as I mentioned previously, anything that affects the ganglion cells, any part of the ganglion cells could essentially cause an optic nerve head disease, whether it's glaucoma, whether it's optic disc edema, whether it's ION or something else, because the ganglion cells feed into the optic nerve. So going back to that previous slide, it would make sense that if this is an optic nerve head disorder, that your GCC should be abnormal. Essentially, it is in this case. Okay, so the B scans are normal. The retinal thickness map showed an area of thinning superior, and that ganglion cell map was clearly outside of normal limits. So what do we do? Okay, what do we do with this? We need to do more testing. Okay, the patient's symptomatic, we're picking up on something, we need to get more testing. So now we go ahead and we get our non-dilated fundus photos, because the idea here is we want to be able to stack again the fundus photos with the screening OCT and compare the picture with the screening OCT. So here we have it, and we see that that right nerve does not look normal. We can clearly see that there's some pallor, some sectoral pallor on the temporal side of the disc. And if you look really closely, there's even some swelling associated with that pallor. Okay? So now it would make sense when you look back at your GCC and you can see that the GCC is red in the exact area of abnormality superior that's abnormal on the disc. The fact that there's some pallor indicates chronicity of the condition. You don't get pallor overnight. There's still a little bit of swelling, which is the acute part, but the pallor would indicate the fact that this condition is not brand new. Let's go and see now how the structural findings that we just saw in OCT correlate functionally. How is the patient seeing? Has this pallor, has this ganglion cell loss affected the patient's functional status? So we go and we get a visual field. We can clearly see that this patient has what we call an inferior altitudinal defect. That's when the midline is completely respected. And this defect is almost always related to an NAION or an ION. Okay, whether it's a superior altitudinal or an inferior altitudinal defect, they're highly correlated with ION. So now, you look at the GCC, you look at the nerve, and you look at the OCT, and the visual field, everything together, and you make a diagnosis presumptively, before you even see the patient, that there's an ION going on or an NAION going on. Okay? Structure certainly does match function in this particular case. So now you have some idea of what's going on with this patient, and you're going to intervene, you're going to come in and you're going to get the information that you need. You're going to do a slit lamp exam. Okay? We're going to check intraocular pressure, and it's important because if a patient has one of these random inflammatory processes going on that's causing the nerve to look funny, the pressure may be high or low. So we don't want to take pressure for granted. Get a good pressure. Make sure you do it. Do a good anterior segment evaluation. Okay? Ask the patient, does your lid flip at night ever? Because that might be an indication of sleep apnea. The patient may have their wife with them or their husband with them, and they can confirm, yes, my husband snores like crazy. So they may not even know that they have sleep apnea, and that might be something that you want to send them out for. Okay, because that again can cause that shutoff of blood supply to the eye, which can result in the NAION. So having another family member that's with them that knows their sleeping habits is actually extremely important. Also assessing, I can't emphasize the importance of assessing the vitreous and aqueous in these patients, okay? Because again, optic nerve swelling, ischemia to the nerve, can result from inflammatory conditions. So we need to make sure there's no evidence of TB, syphilis, sarcoid, which may manifest as aqueous or vitreous cells, and it could be easily missed. So make sure that you inspect the chambers very, very carefully. Once you've obtained all of this testing and you've done slit lamp and you know pretty much what you're dealing with, you go back to your screening OCT. You remember that it was abnormal on the GCC, And we want to now obtain our specialty testing, our specialized testing. And we can sit down at the machine and we can choose what exactly we want to do. So I always start off in any nerve condition doing a 3D optic nerve. Because remember, if you recall what the normal contour of the nerve looks like, you get that normal U-shaped pit, not pit, but normal U-shaped contour, which would correlate with the optic nerve shape. If you have a swollen nerve, the contour is often absent. So in this particular patient, recall we said there was a little bit of pallor and some sectoral edema, and that's exactly what you see on the OCT images here. You can see an absence of that normal nice shape that you get on the OCT because there's swelling of the tissue. So if anything, the 3D optic nerve had confirmed the presence of optic nerve head edema or optic nerve head swelling. Then we go and we look at the RNFL. Very important to look at the RNFL because we want to see how the peripapillary space is affected. We can do a hemispheric analysis, which compares hemispheres, superior to inferior. And we also can do the T-SNP tracing, which again looks at each quadrant of the nerve fiber layer. So if you recall, I put the photo on the top, our problem was superior temporal. That's where the pallor and the edema was. So when you go and you look at the nerve fiber layer here, recall from previous webinars that the ring around the nerve shows a statistical significance. That red area, superior and superior temporal, is telling us that that rim tissue in that area is outside norms for that patient. And then you look inside the actual substance of the nerve, and on a micron scale, you can see how dark that area is. There's thinning of that tissue there because there's atrophy, there's pallor. So it makes sense. It's being highlighted as abnormal because it's abnormally thin. And inferior off of the peripapillary space, you can see the nice red-green color that you want to see because it's supposed to be thick there. But we're missing that superior, and that correlates with the photo. If you look at the hemispheric analysis, it's the same thing. The inferior is that nice green color, but superior, it's red. It's abnormal. Okay? Correlating again with your nerve fiber layer. On your T-SNP map, we're looking for that double hump. Should go up inferior, it should go up superior. Well, it's going up on the inferior side, but it's not going up on the superior side. So everything makes sense. Again, looking at that micron scale, noticing what I circled there, that dark black color, indicating thinning of the tissue. What else can the OCT tell us? It can give us a numerical evaluation of what's going on. If you look at the superior RNFL, it's measuring on average at a 54 microns, where if you look average inferior, it's at 93. There's almost a 40 micron difference in thickness between the superior and inferior tissue. So just in case you're having trouble assessing the actual image, you can look at the numbers, and the numbers tell a story that go along with the image. What about the GCC? What does the GCC tell us? Well, if you recall from the eye wellness scan from the screening, we had that whole area superiorly that was abnormal, that was outside the normal limits. That's that red section. If you were to put that into a thickness, color-coded map, you see that dark navy, or that black again, that indicates thinning. Remember what the normal GCC looks like. You want that green ring around the black fovea. The black fovea is avascular, it should be black, has no ganglion cells. But around it there should be a nice green ring. It's missing here. All we see is inferior, because inferior the tissue's intact. Superior it's missing. And again, on the GCC hemispheric analysis, you could compare the tissue superior to inferior and see again the change in the tissue between the healthy and the not healthy. So now you sum it all up. The rubric, again, that we presented, we started with a history. We put a lot of emphasis on medications. Okay, what medications is the patient taking? Are they medications that can result directly in an optic neuropathy? Or are they taking blood pressure medications or antidepressants or those other classes of medications that can lead to nocturnal hypotension? Okay, because those two things can result in poor ischemia to the nerve, poor perfusion to the nerve. We talked about family history and how ION is not really a disease that runs in families. We did a screening OCT where we picked up our first indication of abnormality. Okay, we found that GCC that was outside normal limits. We got some non-dilated fundus photos which confirmed the presence of a problem. It showed us superior temporal. In that eye, there was a problem. There was pallor and some edema that correlated with our screening exam. We got an excellent slit lamp and ruled out any inflammatory processes that may have been contributing to the problem. Okay? We got a visual field test that showed us the altitudinal defect and really confirmed the diagnosis for us. We did an OCT analysis. We did the RNFL and GCC and got some great information comparing the inferior and superior tissues to each other and seeing how much the actual sick tissue was affected. And then we made a final plan for this patient. So the management, the follow-up, what are we going to do with this patient? Okay? We're going to do a full blood workup. Remember that it's a unilateral condition. If you recall, we want to worry about things like an NAION versus an AION. Okay? In order to rule out an AION, or the bad one, the GCA, we need to get a blood workup. Okay? Particularly the SED rate. Right? The SED rate for a man normally is their age over 2. For a woman, it's age plus 10 over 2. So we want to look at the SED rate and the C-reactive protein in particular, because in GCA that number is going to be very, very high. Okay? We want to get a medical evaluation. If the patient doesn't know that they're diabetic or hypertensive, we need to evaluate that, because NAION is very, very highly linked with microvascular disease. So if they come into us with this diagnosis and they don't have a medical history, we need to make sure they don't really have a medical history. It's not that they haven't seen a doctor in 15 years. Okay, so that's crucial. If GCA is suspected, okay, if the patient is sick and they're reporting jaw claudication and pain on, combing their hair, we send them immediately for the temporal artery biopsy. We would get an MRI and lumbar puncture if necessary. Okay, usually these conditions can be made based on blood work and systemic history, but sometimes they can't. Okay, and if they can't, then we have to go ahead and get more ancillary testing. So let's do an example here of a patient that has optic neuropathy, or ION, and it's an acute case, because if you recall, the one that we just talked about, the patient had some indication of pallor on the nerve, which means that it's not a brand new situation. Okay, it means that there's some evidence that the patient's, it's been lingering around for a while. Okay, here's a 60-year-old white male who complains of a cloud over the inferior part of his vision in the right eye for 2 weeks. Okay, tells me when he comes in, he's a very good historian, and is able to tell me that something funny is going on with his right eye. And we're actually able to pick up on confrontation fields that he can see, but it's not as well as he can see in his other eye. Okay, so there's something going on in that right eye. He actually has a history of nocturnal hypotension, so that helps. Because before we even see the patient, we have some idea that maybe there's an ischemic component to this patient's problem. He has a mild APD in that eye too, which is interesting. Everything else was pretty unremarkable. Okay, he was a man in pretty good health. He told me that he did follow often with his primary care doctor, and that really there was nothing going on with him except that history of nocturnal hypotension. So we get the screening OCT report, and we can see that it looks pretty unremarkable. The B scans look perfect. The retinal thickness maps look perfect. They're nice and green, exactly where we would want them to be. Look at the GCCs, they're perfect. Okay? They have that nice green donut around them. So the first thing I'm thinking of is, I know this patient has a problem, right? He's complaining of something in his left eye. It's substantiated when I do fields. I can tell something's off. So my first thought is, maybe this is so brand new that the ganglion cells haven't been affected yet. Because remember, it takes time for damage to occur. So in the previous case, the one I talked about at the very beginning, the patient may have had that problem for a longer period of time, and that's why the GCC was affected in that eye. You recall that big red area, okay? But in this patient, he looks pretty clean. But you can't stop there. He's obviously having a problem, and if you were with us for the papilledema lecture, it was a similar situation. The screening OCT was normal, but the patient was legitimate, and they were having a problem. So it's our job to move forward now and try to figure out what's going on. So we go ahead and we get a disc evaluation, okay? And here you can see that there's clearly a problem in that right eye, okay? You can see that there is swelling, there is flame-shaped hemorrhages off the disc, and that left eye looks perfectly fine. So there's clearly something going on here that would substantiate what that patient was complaining about, okay? And again, look at your OCT on the bottom. They really don't correlate, right? But again, the thought process here is it's such an acute attack, or we just caught it, that it hasn't yet manifested on the OCT. What about getting a visual field, right? We want to see if there's been any functional damage. We know that structurally, nothing has happened yet because the OCT was fine. What about functionally? Has anything manifested? Well, you can clearly see a superior altitudinal defect there on that right eye, which is the eye that the problem is in. The swollen nerve, altitudinal defect, whereas the left eye looks fine. So we can confirm in our minds now that there's something going on there. We're suspecting, based on the visual field and the optic nerve head appearance and the symptomatology, that it's an NAION, okay, and the fact that he has a nocturnal hypotension. So then we go ahead and we get our 3D nerve scans, okay, because our 3D nerve scans are going to confirm the presence of edema, okay. Are we going to see the normal optic nerve head contour that we see in a normal nerve? So here you can see the swelling or the absence of that normal contour that we've seen so many times throughout the presentation. You can see the heaping of that peripapillary tissue, which goes along with exactly what we're seeing on the patient presentation. What about the nerve fiber layer analysis? Okay? Again, looking at the ring around the circle, that shows us the significance of those numbers compared to the population. And again, it's green. Why is it green? Because this patient it's acute. Nothing yet has happened to the RNFL and GCC. It's such a fresh presentation that it has not been affected yet. However, if you look inside the circle, remember that that's the micron scale. That shows us the thickness of the tissue. And you can clearly see how red the peripapillary space is. That correlates with that warm or that thickening, the elevation of the tissue, especially superior there. Okay, and I circled on the micron scale so you can see just how hot those colors are. What else do you notice? There's no cup, right? The nerve is so swollen that the OCT couldn't pick up a cup. So it's just a big gray circle there with the absence of a cup. And on the bottom, on the T-SNP map, we'll be looking for that double hump, if you recall. We want our superior and inferior for it to go up, double hump. This goes beyond the normal green contour that we want to see because of the elevation. So you can see that black line, which shows you here, inferior, that's where the patient's problem is. And that's where that line is going outside the norm. So you recall the picture where the patient had the flame-shaped hemorrhage and edema inferior. That's correlating with this nerve fiber layer analysis where that line is going into the white. So everything's making pretty good sense here. Then we look at the hemispheric analysis. The nice thing about this patient is that one part of the disc, the superior part, was clean. It was the inferior part that was hyperemic and edematous. So you have the ability now to compare superior to inferior. And even though, recall, the numbers are green, okay, it's an acute situation, it's swollen, there hasn't been any long-term damage yet. If you compare the numbers, superior and inferior, you're going to see some difference in the values. Okay, Okay, the swelling is going to perhaps make the numbers higher than they would in the normal situation. So you can use the patient's normal part of their eye to compare. That's what they should be at. So if superior, who's at 150, let's say, and inferior, they're at 194, you could compare those numbers and say he's 45 microns thicker than he would be in the normal situation. And then on the right-hand side of the slide, you can juxtapose the right and left eye on top of each other and see the difference in the two eyes. The other eye was normal, and you can see how much flatter the curve is than this edematous eye. You can do a dilated fundus exam, and you can see what the normal eye looks like compared to the abnormal eye. Okay? That abnormal eye is engorged, tortuous. The veins are extremely thick and dilated. There's obscuration of the lid margin, inferior, in that area where there's hemorrhaging and edema, okay, compared to the other eye. All pointing in the direction of an NAION. What else can the OCT show us? Look at the values, look at the numbers on the OCT, okay? Remember we talked about discs at risk, right? We said that NAION, one of the risk factors is actually having a small disc. A small disc has less perfusion than a larger disc. Look at the numbers here. The disc areas are very small, 1.85 and 1 point something, and there's no cups, even in the healthy eye, because remember I always said you can compare healthy to not healthy or normal to abnormal. Even in the normal eye, there was no cup. There's your indication that this patient had discs at risk before we even started with the nocturnal hypotension and all that stuff. He was at risk before he even was born, okay? He had small discs, and that put this patient at risk of developing NAION. So it's almost like he was at the plateau, and then he had one risk factor that pushed him over the hill. And that's the situation in this case. So the summation, again, what we went through with him is we had the history of the nocturnal hypotension. He was complaining to us about decreased vision or some kind of problem, inferior, in his eye, okay? We went ahead and we got a screening exam, which didn't give us very much information because it's acute, okay? He wasn't affected yet. The GCC hadn't been affected yet. We got the disc photos and confirmed that essentially there was a problem in that right eye, which is the eye that he was complaining about. We got a visual field, which showed us the altitudinal defect, which put the problem into a functional status, and we were able to compare. We got some high definition OCT images. We looked at the RNFL, the hemispheric analysis, the T-SNP maps, and we were able to evaluate as a whole that this patient had damage inferior on their nerve, didn't have structural damage yet, but did have functional damage. This patient should probably be evaluated for diabetes and high blood pressure, even though he tells me he doesn't have it. He did have discs at risk. We found that out from the OCT. So that's another excellent thing that the OCT can provide you with. If you're not sure if a patient had, let's say the patient has bilateral disc edema and you're not sure what the cups were like before, you can get the OCT to tell you. Gives you great information. So the summation of this patient was recent onset, quote unquote, vision loss or disturbance of their vision in that right eye. He was an elderly gentleman with nocturnal hypotension. Everything was pretty normal except that pupil was not responding exactly correctly. He had a normal GCC and retinal thickness because, again, the acute nature of the presentation. His RNFL was abnormal. We saw in the T-SNP map that it went up into the white zone, indicating that thickness. He had unilateral sectoral disc swelling. So what do? Always, always rule out GCA. He's elderly, okay? We don't want to ignore the fact that he may actually have giant cell, okay? We send them for the full blood workup. We talked about getting ESR. Men is age over 2, women is age plus 10 over 2. Getting that full medical evaluation to make sure he doesn't have diabetes or high blood pressure, even though he tells you he doesn't. Getting a temporal artery biopsy stat if you at all suspect that there's GCA. And then the MRI and lumbar puncture as necessary. The management plan we just talked about, always make sure that there's no toxicity potential, because we mentioned at the beginning of the presentation that if a patient's taking a medication that could cause optic nerve problems, that needs to be ruled out immediately, okay? Because then we're leading the horse in the wrong direction. And obviously always rule out giant cell. I can't stress that enough. We all know the warning signs of giant cell: headache, jaw claudication, the scalp tenderness, proximal muscle and joint aches, weight loss. They are sick patients. They're going to have an APD. They're going to have severe vision loss. I mean, they're going to come into your office very sick. They may have a cranial nerve palsy. And with experience over time, you can tell which patients you should be worried about, suspicious about. Patients that have, a ton of recent weight loss. Elderly, sickly patients. There's a big difference between those patients that have giant cell than patients that just have a regular NAION. We initiate a management plan for these patients, okay? We have to modify lifestyle. If the patient's on blood pressure medications, we talked a lot before about how those medications can really alter the status of the patient. In other words, it can cause a big drop in blood pressure at night. So we have to co-manage with the internist and make sure that the patient's blood pressure is being managed appropriately, that they're not getting large dips in blood pressure at night, okay? Diabetes. Do they have diabetes? Again, most of these patients haven't had blood work done in years. Okay? Send them for blood work. Get a consult for sleep apnea. We talked before about this link between sleep apnea and nocturnal hypotension. That's not something patients usually think of, and it's not part of a normal workup for these patients. Healthy body weight always can lead to sleep. If they're obese, it could lead to sleep apnea. Okay, so everything kind of has a domino effect. And then avoid smoking. Very dangerous, causes ischemia to the eye and all the other parts of the body. Back to this case, the patient was referred for a neuro-ophthalmology consult and was confirmed the diagnosis of an NAION. So even if you didn't have OCT in this case, you could get the altitudinal defect and look at the nerve and put the two to two together. But it's very important, especially when you're looking at progression over time, to have that OCT and to look how the GCC has changed. Has the RNFL changed? And you can monitor how the patient's doing. Here's a clinical pearl that I want to emphasize in this presentation. Depending on when the patient presents, if they presented acutely, they woke up one day and they came in immediately, versus if the patient had been lingering around for a couple of weeks with the problem, your testing is going to look different, okay? Your visual field in an acute AION may or may not manifest yet with a full altitudinal defect. You may just have an enlarged blind spot, or you may just have some random points. Whereas a patient that has a chronic NAION is going to have an altitudinal defect most often. So those images on top show you that sometimes the visual field isn't affected yet. It depends when you catch it. You can see that in an acute case, you're going to have edema. In a chronic case, you're going to have more pallor, okay? You can see the difference in the optic nerve head contour. In an acute case, you're going to have the edema, and you may not have that nice contour. Whereas in a chronic case, the contour is going to go back to normal, okay? And then the T-SNP map. In a chronic case, it's going to be flat because the tissue's lost, it's dead, it's old, it's not good anymore. In the acute case, you're going to have that T-SNP map above the normal green because there's thickening, there's elevation to the tissue. And remember that the GCC may not be affected yet in an acute case, whereas in the chronic case, which I showed you, that GCC was all red because it showed that the ganglion cell complex had suffered enough that the damage was apparent. So it's very important to understand that not every case is going to present the same way. And we don't know how long the patients wait before they come in. So if they waited 2 weeks, it's going to look very different from a patient that woke up that day and came in. So you have to have the wherewithal to look at the picture, the patient history, and put all the pieces together. You can't look at a cookbook and expect every case to follow the same pattern. And this is the clinical pearl to kind of take home. that you should remember how each aspect of that printout is going to change depending on the duration of the disease. Thank you.